Welcome to today's webinar, Improving Treatment Adherence in Teens, featuring Dr. Pooja Mehta. Dr. Pooja Mehta is a pediatric gastroenterologist at Children's Hospital, Colorado. Her clinical and research interests include finding innovative methods of improving treatment adherence in adolescents and young adults with eosinophilic esophagitis, or EOE. Specifically, she is interested in the application of health psychology and in the use of digital health tools to reach patients outside of the traditional clinical setting. Her goals are to perform multidisciplinary and pragmatic research with patient input to improve outcomes in EOE. Welcome, Dr. Mehta.
Hi, everyone. I am just going to start sharing my screen. Well, thank you, everyone. Thanks for having me today. A little bit about myself. My name is Pooja Mehta. I am one of the pediatric gastroenterologists at Children's Hospital, Colorado. I am part of the gastrointestinal eosinophilic diseases program there, which is a multidisciplinary clinic that cares for kids with eosinophilic GI diseases. I'm also a clinical researcher, and I focus on treatment adherence. And I think most importantly, I am a parent to two children, and one of my kids has multiple food allergies. So not EOE, but I definitely understand just kind of the challenges of navigating life with a child with a chronic disease, both in the hospital and at home. So I am excited to be talking to you guys today about treatment adherence in teens, and I think we'll have plenty of time for questions afterwards. So I'm going to start with a little bit of a cautionary tale. I don't know how many people have heard of this or seen this, but Scared Straight is a documentary that came out like in the 1970s. And what it essentially was it took kids who were at risk for, entering jail or entering the criminal justice system and said, okay, well, we're going to take these kids while they're still somewhat young and have them interact with people who are in prison or see what life is like when they're actually in prison. Makes sense, right? And this documentary got a lot of press. People really liked it. And after this documentary came out, a series of these programs kind of opened up all across the country, thinking, hey, this might be the way to kind of change kids' behaviors, change teens' behaviors, and save them. So the big question after 30, 40 years of these programs that everyone has had is, do they work? And the reason I'm bringing this up is because this seems intuitive, right? It seems like if I just show a teenager or a child what's going to happen to them, then they're going to change their ways. And so lots and lots of research has been done regarding these kind of Scared Straight type programs, and a kind of a synthesis or taking all this research together, what they actually found was that not only do these programs not work, but the kids who are part of these programs actually ended up having higher rates of delinquency when you compared it to kids who were kind of in similar situations to them, but didn't enter this program. So, I think the reason that I bring this up is really to talk about how behavior is really, really complex, and changing someone's behavior is complex as well. And so while I wish we could just show everyone a video and say, aha, you're going to take your medicines forever, it's not that simple, but there are some tools that we can use. So my goals for this talk really are straightforward. So I'm going to be talking about the complications of non-adherence in EOE, but a lot of this can apply to other diseases as well. Talk about the barrier. So why are teenagers not taking their medicine? What has been shown in our literature? Describe research that's out there as it relates to EOE treatment adherence. And then finally, talk about strategies that either teenagers can employ themselves, if any are watching, or resources and strategies that parents can use if they are trying to help their teenager navigate this. So first, let's talk about the complications of medication non-adherence in EOE. So a little bit of background. I know people probably know a lot of this, But 25% or 1 out of 4 kids now have a chronic health condition, and this incidence is growing. So gone are those days where, kids took, amoxicillin for a strep infection for 10 days and that was it. 1 in 4 kids are dealing with something chronically where they are having to take a medicine or deal with a treatment on a day-to-day basis. EOE specifically, it's been described for about 30 years. Before, we used to think it affected 1 in 10,000 people. Now we know it affects a greater number, some reports of 1 in 1,000 people, and this incidence is continuing to rise. So we're going to see more and more kids with EOE as the years progress. Adolescents in general are more at risk for not taking their medicines. And it makes sense, right? If adolescents have unique struggles, they often struggle with independence, finding themselves. They have questions regarding self-esteem, who they are. And then they have a lot of difficulty with executive functioning. So do they have the skills required to really manage a medically complex disease, or perhaps a lot of medicines all at once? So is taking medicines a problem for teens? You probably have guessed yes, either because you have a teen, are a teen, we're doing a webinar on this. So it is. And while I'm going to talk a little bit more about it, I want to define adherence as we relate to this presentation. So adherence is used a lot in the medical literature, and basically it means to what extent does a patient's behavior, so in this case, our teenager's behavior, match the recommendations of their prescriber. So non-adherence is the #1 cause of treatment failure in all pediatric chronic diseases. So it is a problem. So why does it matter? So what happens if teenagers don't take their EOE medicines? I'm not going to try and scare you straight or scare a teen straight, but I do think it's important to know, like, what are the long-term implications? Why do we care about this? So this is going to be the only picture of like a real esophagus that I am showing in this presentation. But these pictures are pictures of an esophagus with EOE. I'm just going to kind of walk you through what we see as gastroenterologists. So right here in A, this part, if you could see my cursor right here on the right side, is a very healthy looking part of the esophagus. We like to see that beautiful color. I like to see those blood vessels kind of flowing through. If we look on the top left, this part of the esophagus doesn't look as healthy. You can see that it's missing some of those blood vessels, and it looks a little bit thicker, not as healthy. In B, these are really our classic findings of EOE that you might see, these circles that are kind of going around and around the esophagus, these lines that are going down. And you can see that we're really missing all those nice blood vessels that we're seeing over here. In C, similarly, we're seeing some of those circles, we're seeing some of those lines. I'm not seeing blood vessels. I'm seeing a little bit of some white plaques and some just kind of thickness. This tells me that this esophagus is swollen. And then finally in D, we're seeing some of those same things, missing blood vessels, some of those circles, and then some white plaques kind of all throughout. So this is what we expect to see, not always, but in an esophagus that of someone who has eosinophilic esophagitis, we're going to see some inflammation. So if you have EOE, eventually, if it's not treated, that esophagus with all of that inflammation is going to remodel and it's going to become fibrotic. So fibrotic is just another word for like scarred down, not really moving as well as it should. You might hear this referred to as fibrostenotic EOE, meaning this is a scarred down esophagus. This graph right here on the right shows me or shows us what are the chances of developing that really scarred down esophagus. And this right here on like the vertical axis or the y-axis, it tells us the chances, the probability. And on the bottom, on the x-axis, we're seeing age. So as you get older, the chances of getting that really scarred down esophagus increases over time. And you can say, maybe around 40 years old, there's about a 50% chance that your esophagus with EOE is going to get scarred down. So why do we care if the esophagus is scarred down? What effect does that have? Well, when you get fibrostenotic EOE, we know that it can lead to complications. The one that people often think about is food impactions. So food impaction meaning, a piece of food gets stuck. When it gets stuck, it can be really uncomfortable. Kids are often drooling. It can be painful. They're unable to eat or drink or keep themselves hydrated. And it's important to know that about a third, so 1 out of 3 adult patients with EOE will have a food impaction that requires removal via endoscopy. For kids, if they're having an endoscopy, it adds some extra element of risk. Besides having that endoscopy, they often also need general anesthesia for that procedure to actually occur. And then the other thing is, if that food impaction sits there for a long time, the natural response of the body, if there's food stuck there, is to start retching, is to start vomiting. And if this is happening for a long time, you can actually get a tear forming in the esophagus, and that tear can often require surgery and be dangerous to patients. The last thing that can happen is when we have this remodeling of the esophagus, when the esophagus changes its shape, changes how it moves, it can also change that lower esophageal sphincter. So that is kind of the flap that connects the esophagus to the stomach, and that flap won't work as well. So even if someone didn't have reflux, they might actually develop reflux over time as their esophagus changes. So that flap's not working. So not only do they have EOE, they're also getting reflux of their stomach acids into their esophagus. So a question that a lot of people have is, how long, like how much time do I have? How long does it take to develop this fibrostenotic EOE? And this is kind of a drawing, so not a real esophagus, but a drawing of the esophagus over time. And you can see that most children have this kind of inflammation. The esophagus is still a normal, like a normal size, but as time goes on, we see that scarring eventually develop as people become adults. And our thought, again, EOE research is kind of growing and evolving, but we think that if EOE goes untreated, that this would eventually develop. We'd get that scarred down esophagus in about 10 years. But the good thing, and the reason I care about adherence, is that we know that if you are treated with topical steroids or with swallowed steroids, we can prevent this from happening. Because once you're here, it's really hard or impossible to go back to this once we have that scarred down esophagus. So it's really important that before we get there, we really try and treat it as much as we can. So besides the actual esophagus, we know that not taking medicines in multiple diseases is really associated with poor quality of life. And in EOE, having repeated food impactions really lowers a person's quality of life. They're in the ER, they're uncomfortable. If their esophagus is not working well, they might not want to eat as much food, or they might be afraid to go out to eat or eat certain things. And then, kind of in a bigger global health perspective, we know that non-adherence, not taking your medicine, leads to increased use of health services, right? So you're going to go to the ER when you have that food impaction, and it's going to cost more from a global standpoint. And the thought is that non-adherence really adds up to about $100 billion in preventable healthcare costs. There are some estimates, especially if you're including adults in these estimates, that about over $300 billion in just kind of non-adherence related healthcare costs alone. There's one interesting study that I just wanted to point out, but this is looking at kids with asthma. But it's very similar to EOE in that many kids with asthma are prescribed kind of daily steroid use twice a day. And if you take kids with asthma in just like 14 of the states in the South, and if we had just 40% of those kids who were prescribed twice a day inhaled steroids, and had them take them more, you could save $8.2 million in just those areas. So I think that's all I'm going to do in terms of the scaring straight. Again, you know, it sounds scary, but I think the good news is that we can do things to prevent that from happening. And while it is scary, all of these complications that can happen, that is not the driving force for why people don't take their medicines long term. So now I'm going to describe some of the common barriers for medication taking for teens. I will be focusing on EOE, but again, this really applies across the board. So there is data that shows that, yes, different diseases have different things that people struggle with, but when we're talking about barriers for taking medicines, they're really similar across all conditions. So I'm going to talk about kind of the top 6 reasons that teens stop taking their medicines. So the first reason that people often stop taking their medicines is side effects. So when it comes to EOE, it's a newer disease. We've really described it for 30 years or so. And because of that, a lot of people reasonably have concerns about, well, you haven't really studied what's going to happen to patients if they take these medicines for a long time. So that worry about potential side effects, you know, could stop someone from taking their medicines, and especially if it's not something that's discussed by healthcare providers. Teenagers in particular, when talking about side effects, have a lot of concerns about their physical appearance. If you've been around a teenager, you know, they're taking selfies. They're more concerned about their appearance than perhaps some older adults. And it might be something that they don't actually talk to either their families about. It might be something that they don't actually talk to their healthcare providers about, but it is something they worry about. With regards to swallowed steroids, while we think that that doesn't have some of those effects of like acne or weight gain, it's something, it's not something that teenagers might know. They hear the word steroids and they think, oh my gosh, I'm going to really change the way I look. And they might not be really forthcoming about how they feel about that. It might be something they're embarrassed to talk about, and they might just stop taking their medicines. The next reason that people kind of stop taking their medicines, or teenagers or even adults, is because they feel better. EOE, we know, is a chronic disease, but many people think of it as occurring in flares. So they think, oh, my EOE is active or my EOE is not active. Well, that's not the case. We know that EOE, you're going to have it regardless of whether you have symptoms. I think that's an important thing to talk to teenagers about, is that even if you don't have symptoms in EOE, it doesn't mean that there's no inflammation going on in the esophagus. So sometimes they're like, well, I'm feeling good. I'm not having a flare of my EOE, so I'm not going to take my medicine. But that's not necessarily true. Symptoms and what we're seeing in terms of inflammation and risk for developing that scarring down are not one and one. They don't necessarily go hand in hand. The other thing is symptoms in EOE can be subtle. They're not that obvious. About 50% of people actually also have chest pain that's unrelated to swallowing. So they might have some pain in their chest that they're not associating with EOE because it's not pain while they're swallowing food. And then the last thing is that even though someone might think they don't have symptoms, because EOE is kind of this slow, chronic, progressive disease, people will change their eating habits and not necessarily realize that. So people might start eating slowly, but they're not realizing it. They might start avoiding certain foods and not really attributing that to active EOE. Maybe they don't want to eat steak, but it's not something that they're really doing consciously. It's something that happens subconsciously. Because of this, often people will kind of do a trial. They'll say, all right, well, you know, I'm feeling pretty good. Let me just stop taking my medicines and see if I really need them. And if they stop taking their medicines, they might not notice a change, but there's still damage going on the inside because they're doing some of these other things. You know, they might not have symptoms, or their symptoms might be subtle that they don't really attribute to EOE. So the third thing is really in terms of the actual medicine itself. So a lot of people teenagers in particular, don't have difficulty swallowing, swallowing pills. And then when we're talking about EOE, sometimes, we're mixing budesonide with all sorts of different things, and that can be off-putting. So, especially you're mixing it with Splenda, or you're mixing it with honey, that taste over time, doing it twice a day, can be kind of exhausting to teenagers, and they just don't want to do it anymore. It's gross to them. The other thing that's difficult with regards to EOE is just not eating or drinking afterwards. That's something that needs to be planned for when they're taking their medicines. And sometimes kids forget, or they get that medicine in, but then they'll eat or drink something right afterwards, and that can be challenging. So the next thing is forgetting, and forgetting is the most common reason that teenagers don't take their medicines across the board, regardless of what disease you're looking at. The most common reason that teenagers won't take their medicine is they just kind of forget. The things that they say is, well, I had a change in plans, I was gonna go home, but I ended up going somewhere else. I didn't have my medicine on me. I had a meeting, something unexpected came up. Traveling or vacation is a common time that people forget to take their medicines. Sometimes they don't even pack them. And so we're, 2 weeks down the road, we haven't taken our medicine. And then sometimes if you really just talk to kids, they're just like, I don't know, I just forget. I can't explain to you why, but I just forget. So the next reason, and this seems to be more particular to teenagers, is they want to be normal. So teens often connect their disease to feeling not normal or not fitting in, which is a big thing for teenagers. We know that if they do feel normal, it is linked to taking their medicines more. And then bullying is another reason that we'll see kids not want to take their medicines, or not even reveal that they have a disease. So, if there's bullying around them, or if they're in a situation where bullying is a thing at school, regardless of whether they're being bullied or other people are being bullied, they feel like, gosh, if I reveal that I have to take a medicine, it's going to be like the instigating point. And I'm going to be bullied more, so I'm just not going to do it. I'm not going to take it. I don't want that risk. And then the last thing is lack of support. Teenagers need support from their peers. They need support from healthcare providers, and they need support from their family, from their parents or their guardians. With regards to peers, now while all teens need some degree of peer support, there is some literature showing that girls might rely on peer support a little bit more than boys, but regardless, they do need that one or two friends that they can really talk to or be open about. With regards to healthcare providers, the barriers that they often cite are that they don't feel like they can communicate with their healthcare provider. They feel like, maybe their doctor is not really telling them the plan. They're not being included in the plan. They don't like to be treated like a child. This is something that comes up a lot. And they don't like to be ignored when they're in the visit with their doctor. They don't want it to just be like, the guardian or the mom or dad talking to the provider about them. They want to be included in it. I'm going to talk a little bit more about some of the research that's been done with regards to the role of the family when it comes to taking medicines. So it's important to know that some increased family conflict during teenage years is normal, right? And it's usually temporary. And it's important for a teenager to kind of go through this. It helps them kind of establish their independence. And then it also helps them create a new norm. Like, this is what I do, this is what you do. So having some conflict with teenagers is completely normal. And then it's also important to know that if some conflict is normal, if you have a child with a chronic illness, this can lead to increased levels of stress, and that it impacts both the child but the family as a whole. So, we do see impacts on siblings, impacts on parents, and really the whole family dynamic. And then at the same time, how the family interacts also plays a role in how much a child is going to take their medicine and how they can develop the skills for medication taking on their own. So here are the things that have been shown to improve medication adherence with regards to the family in teens. And I'm going to go through some of this, and I just want everyone to like not judge themselves. You know, describing some of these things, it's going to be like, well, I'm not the Brady Bunch, and I get it. But these are the things that we can all kind of strive towards. So low levels of family conflict. So if there's a lot of negativity in the house, if people are fighting, if there's relationship struggles between people in the family, this can impact medication taking. And so lower levels of conflict means higher levels of medication taking in children. And then alternatively, the opposite. So if there's high levels of family cohesion, so feeling like everybody knows each other, it's a caring and a warm environment, they're involved in each other's lives, it's a good relationship, we know that those teenagers tend to take their medicines more often. If there is some family flexibility, so if people have roles, but they're also willing to adapt and change depending on differing circumstances, we know that that can improve medication adherence. And then this is a big one, good family communication. So what that means is when people are communicating kind of with each other, including the teenager. So there's a mutual exchange between the caregiver and the teenager, kind of a back and forth rather than like one person telling them this is how it is. And then family problem solving. So if everyone kind of comes together, and this kind of goes hand in hand with the family communication to try and tackle problem solving together rather than leaving it just on the parents or leaving it just on the child. So a question that comes up a lot is really, well, who should be in charge? Should it be me as a parent? Should it be me as a teen? Whose job is it to take medicines? And that's hard because adolescents struggle with wanting to be independent. They want to not be treated as a child, but also they're still don't have the skills needed to be an adult to really take medicines all on their own. So there really is no like, this is it. Today you take the medicine, I'm in charge of medicines, tomorrow you're in charge of medicines. It's really a process that comes over the course of several years. In looking at the literature and how much people take responsibility depending on their age, about 50% of the responsibility in literature is given to 11-year-olds, about 75% to 15-year-olds. And usually by the time kids are 19, they really have about 100% of the responsibility. Now, these are not like benchmarks that people need to meet. It's really just kind of talking about what families are doing, but every family is unique and individual. And the big thing is that it's going to come over time. In terms of parental involvement, it can be challenging as a parent because being too involved by teenagers has been kind of cited as being like, oh, they're nagging me too much. They're really trying to control me. Again, teenagers want some control, and this can lead to more family conflict. It could lead to fighting back. And this kind of overbearing, really overly worried has been associated with poor medication taking in teenagers. And then providing too much freedom, alternatively, can be perceived by teenagers as like, well, my parents don't care, or nobody else seems to care, so why should I care? And then they're also left to forget more if no one's paying attention. So I'm going to briefly describe research as it relates to EOE treatment adherence. So there's not a lot of research with regards to adherence in EOE, but something we're trying to learn more and more about. In our own institution, we looked at 117 kids with EOE and looked at how often did they say they were taking their medicines. So pretty high when you asked both parents and teenagers, but teenagers did have worse adherence. So when we asked kids and parents, between kids between 5 to 12, they were taking their medicine almost 90% of the time, so pretty high. In teenagers, they said they were taking it about 76% of the time, so 3/4 of the time. And the reason I say they said is because, gosh, is that really what they're doing? That seems really high. So what are like kind of true adherence rates? I know what people say they're doing, but what are they really doing? So we also took 7 teenagers who had EOE between the ages of 13 to 18, who had diseases, who had the disease for different amounts of time. And we asked them to tell us how often are they taking their medicine, but also we gave them this little sensor. So it's kind of like the size of a quarter, and it sat on top of their meter dose inhaler. So they're like flow vent, and it just captured over the course of 2 months how often they were taking their medicine. And what you can see here is they said they were taking their medicine similar to what they said in the other study. So, you know, some people anywhere between high 50s to almost 90%. But when we looked at what their sensor was capturing, all of it was lower than what they said. And these 2 kids particularly, both said they were taking it 86% of the time, but they took it about a quarter, and then 14% of the time. So what are the barriers to medication taking in EOE specifically? So when we looked at barriers in our patients, so demographics, regardless of whether, you know, what sex, what gender, what their income level was, that was not associated with with taking their medicines. Their disease history, including whether they had a food impaction, was not associated with taking their medicines. Their symptoms not associated with medicine taking, and their quality of life was not associated with how much they were going to take their medicines. So I know you're thinking like, oh, what is associated with how often they're taking their medicines? Where can we intervene? And so we ask kids to kind of fill out some questionnaires that really gets to why they're not taking their medicines. And this right here on this y-axis kind of talks about different psychological reasons, for lack of better words, that they associate with medicine taking. So attitude, do they have a good attitude about taking their medicines? Are they confident that they can do it? Do they feel like they have control over it? Like, do they have the inhaler with them? How often do they forget? Do they intend to take their medicine? Is their plan to take their medicine? Do they think it's normal to take medicines? And are they making plans for taking their medicines? The higher numbers, so things that kind of the boxes that are on this side, means that they're pretty good at it. So they have a good attitude about taking their medicines. They know that they need to take it, they want to take it, they feel like they can take it. But where they struggle is they forget to take it, and they just don't make plans for taking it. So based off that, we created something called the medication taking checklist, and kind of based off other literature that we've seen. And this is going to be available. I've given it to you guys if you want it. And basically, it's a conversation starter. And you just have your kids or teenagers fill this out. Should take less than like 2 minutes. And it asks about certain times where they might struggle. So do they take their medicine exactly as instructed? Do they take it when they have a hard time swallowing? Do they take it when they're feeling well? Do they take it when they're really busy? Do they take it on school days or weekends and holidays, when something unexpected happens, when they're traveling? And do they make plans? We took people's answers, teenagers' answers to this, and kids, and kind of compared it to what their actual adherence was. And I know there's a lot of numbers on this table, but basically this number in this column is telling me how associated is it with adherence. The higher the number, the more associated it is. And what you can see is all of these, for the most part, are pretty associated with adherence, except for this difficulty swallowing. That makes sense, right? It's not their symptoms that are driving them taking their medicines, all those other barriers that we were talking about. So I'm going to spend the last couple of minutes really talking about strategies and resources, some that are available, some that are hopefully soon to come, either if you're a teen yourself or for families who are trying to encourage medication taking in people with EOE or any eosinophilic GI disease. So before we get to specific things, I want to talk a little bit about research that's been done on potential solutions. And so there was this 2017 study that looked at like 770 trials in people who are trials that relate to trying to improve people's medication taking. And what they found is that healthcare providers or people who are developing kind of these tips or ways to improve medicine taking really need to focus on behavioral strategies rather than cognitive strategies. What that means is that don't focus on like telling someone or scaring them straight, but really focus on giving them some behavioral tools, specifically habit-based interventions. So how do I make someone develop a habit of taking a medicine? Similar to, you know, brushing your teeth twice a day, that might be a habit. It's not something you think about, it's just something that happens. And that is the goal for medication taking. I want it to become a habit. In this 2020 study, they looked specifically at habit strength and medication adherence, and then mobile health interventions, so cell phone related interventions. And again, looked at tons and tons of studies, and they saw that the more of a habit you have developed for taking medications, the more likely you're going to take a medicine, regardless of which theoretical model. And what I mean by that is there are a lot of kind of health behavior theories or ways to help guide how we think about how people behave. And regardless of which theory or framework you use, if you have a strong habit, you are more likely to take your medicine. So, can technology help teens take their medicines? So if you have a teenager or even been around a teenager, you know that they are constantly on their cell phone. In fact, about 95% of teenagers have access to not only a cell phone, but a smartphone. And this access is actually universal, regardless of their race, their gender, their ethnicity, or kind of their socioeconomic background. They all have smartphones. And when we've looked at interventions that are related to smartphones, they tend to be more effective in teenagers specifically. So teenagers tend to be more inclined to use smartphone related interventions. When I first started doing adherence related research, my thought was like, well, just send them a text message. Why can't we just send text messages? Won't that work? And what we found is, yes, it might work for a little while, but the effect wears off over time. People get tired of getting those text messages. It's not really changing their behavior. So text messages are helpful, but not the ultimate solution. So what it means is that we can use technology, we just need to use it thoughtfully. So here are some potential solutions that we are working on right now, and hopefully you should hear about this, is that we are trying to work on an action plan. You might be familiar with action plans. There's like an asthma action plan, a food allergy action plan, but those are really based on the symptoms. You know, if I'm having a difficult time breathing, if I'm wheezing, what should I do? Our goal is to really create an action plan that focuses on planning and creating a habit rather than relying on symptoms, which is really important in EOE specifically. And then we are also trying to test an app that we created called MedVenture that I'm going to go over with you guys real quick. This app, and I'll show you some screenshots, was created by gastroenterologists, psychologists, software developers who have expertise in health behavior. And then the University of Colorado has something called the mHealth Impact Lab, which is kind of a think tank through the School of Public Health. We created interview guides. We interviewed both healthcare providers and patients. And then we analyzed those interviews and came up with themes. So the themes that we got 3 major themes. And what we found was that lack of routine. So lack of routine contributes to non-adherence, which really fits into the idea of building a habit. If something is a habit, it doesn't matter if you don't have a routine, you're more likely to do it. The other thing we found is that sometimes teens reported purposefully not taking their medicines, and this fits in with some of those barriers we described. So if they feel like it's not normal, or often they cited it as a way of having control over their life. This is something that I can control, or this is a way that I can rebel. If I just don't take my medicines, I know that this is important to my family, and I'm just going to not do it. And the last thing we found when we interviewed healthcare providers, so nurses and physicians, is that yes, they did recognize the importance of adherence. Everyone wanted their patients to take their medicines, but they didn't want to have a tool where they're checking in with their patients. They really wanted to promote patients doing this on their own. How can patients better manage medicine taking by themselves? So after we kind of identified those themes, we integrated those themes with what we know in the literature. We built this app over the course of 4 months that was based on these design and build sprints, where every 2 weeks we would meet and change and modify. And we do have a prototype. What we ended up with was a game. And the reason we picked a game is because games tend to engage teenagers more. And so it is a survival game where people are given rewards for creating habits. And then this is just another little screenshot that you can see. We're trying to engage or let teenagers have more fun with it. So more to come with that. I am partnering with APFED on both of those things. So hopefully you'll hear more. So finally, some tips for parents and guardians based on what we've talked about. I think it's important to have a sincere conversation with your teens. So try to really have an open-ended conversation about why they aren't taking their medicines. Ask specifically about those barriers we discussed. Ask them if they're worried about side effects. Talk to their healthcare provider about side effects. Ask them if the taste is bothering them. Once you know the barriers, you're more likely to be able to intervene on them. And then a big thing is make sure your teen understands that EOE is chronic, and that even if you don't have symptoms, they can still have inflammation going on, and have a conversation with your healthcare provider about that. I think trying to get your teenager engaged in visits is important. I know it can be hard. If they're shy or worried, they can write down questions ahead of time. And if your doctor's not doing it, if your doctor's talking just to the parent or just to the guardian, encourage the doctor to talk to the patient rather than the parent or guardian. The next thing that we know really works is to set goals and to be realistic. So the best thing about goal setting is to set very concrete goals. So instead of saying you're going to be better at taking your medicines, you're going to say, all right, I'm going to try and take my medicines 4 days out of the next 7 days. And then check in, not on a daily basis, but maybe in a couple of days in a really non-judgmental way. Try and identify those problem areas. If they didn't meet their goals, then maybe use that checklist and say, all right, well, let's go over this. Where do you think those problem areas were? There's something called an implementation intention that I often use with my patients in clinic, but it's something that you can do at home as well. Implementation intention is just a really fancy way of saying an if-then statement. So let's say you filled out that checklist and they said, they don't take it on the weekends. Well, then you can say, if I forget to take my medicine on Saturday morning before soccer practice, I will take it after. And just that idea of having a plan, writing it out, or saying it has been shown to improve follow through on things. Use tools that you already have. Alarms on cell phones are good. You don't have to download like a special app that sends medication reminders. Cell phone alarms are great. And then another thing that's really important is visual cues to link to habits they already have. So if you can build on top of a habit they already have, they're more likely to take it. the habits that I've worked with my teenagers in my clinics on are often brushing their teeth, although some teenagers don't brush twice a day. We'll have them physically tape part of their medicine to their toothbrush, so they have to hold it in their hand. Or a lot of times kids charge their cell phones. So unplug in the morning, before the first thing they'll do is grab their cell phone. At night, the last thing they're going to do is charge their cell phone. So having a visual clue linked to the cell phone charger is another way that you can help link to a habit they already have. Like I mentioned, hopefully there's some new tools on the horizon. And then in terms of peer supports, try and encourage your child having that one friend that they can talk to, or join some peer supports where they can join support groups where they might be able to talk to another teenager who has EOE and realize, oh man, it's just, I'm not the only one, I am normal. It's helpful sometimes when they get embarrassed or worried at school to help them find the words to describe their disease. And if they want to, they can practice with you. So if someone asks about their disease, they're not taken aback. They know what to say, and it's not as stressful for them. And then if family life seems too stressful, there's concerns about fitting in, bullying, I think it's important to seek extra help. Within the GDP, or our multidisciplinary clinic, we have a psychologist. There are many psychologists that work with children who have chronic diseases, and I would not be afraid to kind of tap in to these resources to help navigate some of these complex situations. So a quick thank you before we do some questions. I just want to give a big thank you to Dr. Faruda and Dr. Kwan, who are my research mentors, and all of the funders and advocates who've really helped fund research related to adherence and technology and improving outcomes for our kids with EOE, including APFED.
Wonderful. Thank you so much. We really appreciate all the really valuable information that you just provided. The first question we've got is, you mentioned at the very beginning, why should food or drink not be consumed directly after taking medicines for EOE?
So if you think about EOE medicines, the goal is for it to sit on the esophagus and kind of coat the esophagus. So I like to think of it almost as, if someone has eczema and they are putting eczema cream, like a steroid cream, on that patch of eczema. If they put that steroid cream on and then you immediately wash your hands, you are not going to have time for that medicine to really sit and take effect. And so the same thing happens when we take medicines for EOE. You take that swallowed steroid, whether it's through an inhaler or budesonide, and you want it to sit there. Usually people say somewhere between 30 to 60 minutes without having food or drink just wash it off the esophagus.
Makes a lot of sense. Thank you for reinforcing that importance. So several people on here have different age teenagers and things, and have a series of different questions. Do you find that there's any correlation between poor treatment responses and non-adherence?
That is something we are trying to look into. I don't know. I think there is definitely some people who will not respond to medicines, or there might be some patients that don't respond to medicines. EOE, we are learning more about it every day. And so if someone is not taking their medicines, for sure, I would expect it to have some implication on their, when we scope them, and on their biopsy results. If someone has, still has esophageal inflammation, does it mean like we should be like, you're not taking your medicines, you're aligned to me? Not necessarily. But we are trying to figure out what is that exact correlation between medicine taking and what we see under the microscope. I don't have any data, maybe soon.
In follow-up to that, certainly non-adherence can be a big challenge, and sometimes people are, as all your research shows, people are inconsistent in how frequently they're taking their medicine. Is there harm to that inconsistency?
So I think these are all good questions, and questions that we need to figure out. I don't know. I don't know if it's like how much they take it over 2 months, and if it's all, if they took it 50% of the time, or but once every day, did that work? Or was it, for just 1 week on, 1 week off? These are things we don't know. And so these are things that we hope to figure out. I will tell you, with my patients, when they have been inconsistent, we definitely see it on their biopsies.
I thought it was really interesting the way you guys used technology to help track how much people were self-reporting they're taking it versus they're actually taking it. Is there any sort of at-home model of that kind of data tracking that parents could put on the medication to help keep an eye on how often their kids are taking it versus what they tell their parents they're taking it?
Well, so there's a lot of data, or there's people doing this in the asthma world. So in asthma, there are like like albuterol or Flovent that has these built-in trackers already that provide that information. So I think medicine is heading that way. Is there anything for EOE specifically? No. I think we can use asthma as a model, since many of the medicines are similar, or pill counters or pill trackers, to give us that information. We have to do it in a non-judgmental way, rather than being like, why didn't you take your medicines? Life is complex. Being a teenager is hard. And so having that information, I think, is important, but also how we approach that information is also going to be equally as important.
Absolutely. Have you found that there's any difference in how people adhere to taking their medication if they are physically involved in the decision of what type of medication they're going to be taking?
Yes, I think having conversations and having patients be involved in medical decision making is definitely going to play a role. And teenagers kind of pointed to that in all the studies that have been done, in that they want to be involved. They're trying to navigate this independence. And so if they tell you like, hey, I don't like Splenda, then we should listen to them, right? And try it and find a different vehicle to help them. Of course, they're going to not take it if it tastes terrible and they throw up every time.
Definitely sounds like a no-brainer for sure. Sometimes they also, as you mentioned, just get stuck in a mentality of like the meds don't make a difference. Do you have any specific tips for how to combat that mentality?
I think having conversations about it, and it is hard because the meds are not, especially, if kids have other diseases. Let's say they have asthma and they take their albuterol and they feel better, and they think that, well, that should happen with my EOE meds as well. And so I think really educating both parents and the patients about how EOE is chronic and how it is a different disease than food allergies. You're not going to have an immediate reaction if you eat a peanut, and it is different than asthma in that the symptoms don't relate. So really educate, and providers should do this too. Really talk about how it is not a flare and no flare disease. It's something that you got to do ultimately. I think it's important to talk about the complications. Is it going to be lifelong if they get scared in that clinic visit? No, but they should know.
Well, the app and things that you are developing certainly seem like steps in the right direction. What are the next steps for that? Are you at a point where you're needing any volunteers to beta test for you?
We will hopefully be there soon, and I am partnering with APFED. We will hopefully we do need patients to test those apps and provide feedback and change the app. So all of my work is very patient-centric, meaning we want patients and families to provide information as we go. The worst thing would be to like create the app and then like, oh, we didn't even think about this. Maybe we should have talked to a patient who actually has EOE. So yes, there are plans to test it. We are not there yet. Hopefully we will be in the next couple of months. And I'm so lucky to have APFED as a partner with me on trying to find some patients who might be willing to do this.
Well, we're happy to be able to support and partner with you as well. Last question we've got here. You talked about the importance of kids being part of talking with their doctors. At what age do you recommend kids really becoming part of that conversation? I mean, obviously at any point once they can talk, they can be part of those conversations. But at what point do you recommend really encouraging the kids to talk first and the parents to take that step back?
I don't think there's a right answer. I mean, I think kids should be involved from the get-go. You know, a 4-year-old can talk a little bit to their provider. I think we don't want it to be a source of stress. So if there's a teenager that's like so shy, you don't want to be in the office like, you got to talk to your provider, but maybe they can be involved in other ways. Like maybe they can write those questions down ahead of time. And I do think that pediatricians sometimes are so used to talking to the parents that it's okay to redirect them and say, hey, maybe he or she can answer that question for you, so that they can be involved, as even if it's just a little bit. And then, I mean, take their cell phones away during the clinic visit.
They are magnets.
Yeah, they're usually on the Wi-Fi before we've even come into the clinic, or before I've said hello, they're on their phones. But try and get them engaged as much as possible.
And use that technology to your advantage to help remember to take the medicine.
Right, use it wisely.
Absolutely.
Technology is, there's risks with teenagers, but there are also benefits.
Well, before we wrap up today's webinar, is there anything else that you'd like to share with the audience?
Oh no, I mean, I know it's a hard process. And so I think there's no one solution for every child. And I think it's something that's going to come with time and a lot of hard work when it comes to trying to work with a teenager, and to not be so hard on yourself as a parent, but also tap into some of the resources that are available.
Absolutely. Well, thank you so much for joining today. Really, really appreciate all the insights and everything that you shared. Thank you also to our education partners for supporting APFED's EOS Support Webinar Series. Specifically, thank you to AstraZeneca, to Bristol Myers Squibb, and to Takeda. Our next webinar in our series is Self-Advocacy in the Healthcare System. This is a rescheduled webinar that was originally planned for November, but we have our new date. So on December 16th, Patty DeMurray will join us at 1:00 p.m. Eastern Time to be able to talk more about how you can get the most out of your doctor's appointments with your specialists, etc. Really getting prepared for working with your care team. If you're interested in continuing the conversation from today, we encourage you to join APFED's online community. You can connect with other patients and caregivers for support. It's a wonderful online forum. You can access it at apfed.org/connections. Other resources to be able to continue to be involved in APFED, we encourage you to subscribe to our podcast, Real Talk, Eosinophilic Diseases. Our most recent episode featured eosinophilic asthma. We got to speak with Dr. Ravi Vinastaphan about his experiences managing this severe form of asthma. Finally, we also encourage you to check out EOS Connections. For the past 2 years, we've held our annual patient education conference on eosinophil-associated diseases virtually. That means you can continue to access the information for an extended period of time. If you weren't able to join us in July, or even if you were, all the sessions are still available to access on demand. You can watch the recordings of the sessions. You can explore the virtual trade show booth, where you can explore the partners and see their exhibits. You can also explore research that was presented and watch videos from some of the PIs who did the different research, talking about their research. Thank you again for joining us today. If you have any questions, please don't hesitate to reach out. You can email us at mail@apfed.org. Have a great day.